name. Again, my name is Carlos Posey. I'm the clinical director for the Foundation. We're going to talk about trauma, the effect of trauma on the brain, and we're going to try to focus as much as possible on not just so much the trauma, but what you do about it. In conversations with folks here in the conference, we kind of realized that folks are probably more interested in kind of what is their role in the intervention process. So we modify things a little to focus a little bit more on that. With me is Michelle. Michelle is our senior clinical manager at Devereaux, and she's going to be doing part of the presentation, particularly in terms of interventions. I want to take a couple minutes and ask about your questions. What are some of the things that you're interested in hearing about when it comes to trauma and children with disabilities? One at a time.
Methods of addressing the trauma therapeutically, because for many children who are disabled developmentally, who have a lower cognitive functioning, a lot of times you cannot find any organization that is going to do any cognitive therapy, and they may not have the attentional issues to really benefit from traditional cognitive therapy. But at the same time, it is very obvious through their behaviors that they have suffered trauma and continue to be processing that in their own way. So,
Ways of addressing it therapeutically. I'm not going to say that again. You did a good job, right?
I would be interested in looking at ways that we can address trauma in developmentally disabled children, because many of them do not have what is traditionally considered to be a high enough level of cognitive functioning to benefit from traditional cognitive talk therapy or cognitive behavioral therapeutic strategies that are trauma focused. And yet, it is very obvious from their behaviors that they are affected by trauma they have suffered. So we need to be able to address that so they are happier and they can be more successful.
And you know what, along with that, just to piggyback on yours, what about children who are not developmentally delayed, who have the verbal skills, but are emotionally choosing or not ready? You know there's been trauma, but they're just not coming forth with it.
Okay. Anybody else?
How trauma can make a disability worse? And what kind of things?
How trauma can make a disability worse. And there's a quote that I love, which is, disability sometimes causes trauma, in that people with disabilities are higher risk of being traumatized. But then trauma could also cause disability, in that trauma creates difficulties in development, and we see a lot of kind of lack of functioning. Anything else? As we're talking, there you go. As we're talking, if you have questions or comments, please just let us know. Okay? We want this to be as interactive as possible. Yeah. They told us we have to put in two slides at the beginning of the presentation, and I tried to do that, and this is the best I can do. To show you that. Again, our objective is for you to kind of understand a little bit better what the effects of trauma is on individuals with disabilities. To increase your understanding of what the services that are available, the types of therapy and the types of intervention and the purpose of those interventions, and maybe even what those interventions are supposed to look like. Okay? And then to increase your competence in just suggesting services and making referrals, so that when you have a child that is exhibiting those kinds of difficulties, you're in a better position to say, you know what, maybe this kid needs this type of therapy. And if somebody suggests that type of therapy, you kind of have an idea of what that kind of therapy is. Okay? This is my son. I always put in a picture of him because he loves posing every time I'm going to take a picture of him. So my son is 18. His name is Samuel, and he has a developmental disability. Luckily for him, his biggest trauma in life is Friday's supposed to be pizza night. And if we eat anything else, that's a trauma for him. Now, why? Well, let's just skip this one. Okay. A couple of things that we know about children with developmental disabilities and trauma. Children with disabilities and trauma. Like I said before, children with developmental disabilities are at an increased risk for abuse compared to the general population. Now, why do you think that is?
Higher stressors for the caregiver.
A lot higher stressors for the parents. If you've ever had to deal with a child with a disability, you know that both in terms of work, physical work you have to do with your child, also in terms of what it takes out of you emotionally. It's very difficult. Right? Okay. Individuals with disabilities are 4 times more likely to be victims of crime as individuals that are not disabled. So the possibility of individuals with disabilities being traumatized goes beyond what could happen in the home. In the community, they could be victims of crime at a much higher rate. And 64% of children who were maltreated had some kind of a physical or emotional or psychiatric disability. Okay? As I'm sure you guys know, this becomes more of an issue when you have individuals who have limited verbal capacity. Because children with limited verbal capacity can't tell you when they're being abused. And that becomes even a higher difficulty. Okay? Again, a developmental disability is chronic disability of an individual that impairs their regular functioning, diagnosed before the age of 22, and interferes with things that you have to do on a regular basis. I'm not going to read the whole thing. Okay. Now, what is trauma? Like I said before, for my son, trauma is not getting pizza on Friday night. Okay? Sam is very frigid about the things that he does. When he was little, Sam would go to school. He would wake up in the morning, have lunch, take a shower, get dressed, and wait for the bus. Well, at some point, we realized that it would be a lot easier if he would take a shower while we made him breakfast. It took about a year to get Sam to agree that he was going to change his routine and take a shower first and have breakfast later. Okay? That was traumatic for him. But trauma tends to be subjective. And that's why I want to tell you, I tell you that story, because for him, that was a difficult thing. Now, we have an idea, we have a perception of what trauma is. And a traumatic experience, again, it's either a single event or multiple events or a set of circumstances that it's experienced by an individual as physically or emotionally harmful or threatening to them. Okay? And as you can see, it has a great deal of emphasis on the way the individual experienced that experience. Okay? Now, with children with disabilities experience trauma and experience trauma as trauma. Their disability doesn't impede them from experiencing a negative experience as trauma. Okay? They may not be able to tell you that they feel that way, but that doesn't mean that they're not experiencing the trauma. Okay? The disability doesn't impede them from that. Okay? Again, research suggests that early experiences of trauma can affect changes in brain functioning, and these changes can affect the individual's reaction to later trauma. And there's a couple of things that I want you to know about this. When we think about affecting brain functioning, think about two major things. One is the structure of the brain. Many researchers have found that children that have experienced trauma have different structure. The brain is built differently. Okay? Different areas of the brain develop in different ways. And those differences have been associated with trauma. Okay? So when we think about the changes in the brain, think about the structure, the actual brain developing different in children that have experienced trauma. In addition to that, okay, part of the function of the brain is to secrete several hormones and chemicals that make our functioning possible. And children with early experiences of trauma also secrete several chemicals and hormones differently than children that have not experienced trauma. So you have two major ways in which the brain and the functioning of the brain is affected. Okay? Changes, like I said before, in the hypothalamus, the pituitary gland, and the adrenal system. Right? Secretion of hormones. Okay? Now, what exactly does this mean? Well, for children, it means a couple of really basic things. One is experience of difficulty with language and expression. Now, when we talk about experience with difficulty in language with expression, we're not talking only about language delays. We're talking about difficulty finding words to express things that before the trauma they may not have had difficulties finding words. Part of their brains that is affected are going to make it harder for them to talk about the experience and to talk about the experience in a way that adults around them would understand them well. Okay? So even when there is no language difficulty, when there is no language delay, the likelihood is that a child with trauma would have difficulties in expression, in terms of language, and in terms of emotion. Okay? Difficulties with regulating emotions. I have a 4-year-old granddaughter. My daughter's a social worker, and every once in a while, we just sit around and diagnose my granddaughter. We take 10 minutes, and we kind of say, okay, now she's being ADHD. Now she's being bipolar. Okay? Because at the age of 4, children really don't have that great ability to regulate their emotions. When they're mad, you know they're mad. When they're hungry, they'll let you know, right? If they feel sad, you'll see that they feel sad. As we grow, we kind of develop that internal ability to manage how we feel. We may feel bad in one situation and still act different than what we feel. Right? We have the opportunity or the knowledge and skill to delay our emotions. Okay? So we may be thinking about, oh, when I get home tonight, I'm going to have a conversation with Sam about cleaning his room. Okay? And I could wait until tonight to deal with that. Imagine if you couldn't do that. Imagine if you couldn't delay your emotions, if you couldn't hide your emotions, if whatever you felt it in that particular way. And then imagine if that emotional system was just completely whacked and distorted and you're feeling a whole bunch of different things at any moment. Okay? And you're letting everybody in the world know absolutely everything you feel with your behavior. Okay? For many children that experience trauma, that's kind of what's going on in their mind. And with children that have difficulties, with a particular developmental difficulties, that experience just gets worse because they didn't have a good way of communicating to begin with. Difficulties with learning and short-term memory. I remember we had a kid in one of the foster care programs I worked with in Pennsylvania, and the foster mother would say, you know, we go over the rules in the house. He could tell me exactly what I just said, and 10 minutes later, he's just doing what I just told him not to do. Hmm? I would say, yeah, you're right. Because he has difficulties with learning in short-term memory based, part because of his trauma, and part because of his developmental delays and learning disabilities. And he could tell you what he just heard. Ask him 10 minutes later, and he's not going to have a clue of what he said or what it meant. Hmm? Because hypervigilance. If you're walking around, Orlando's probably not a good example, but it is in some way. But if you're walking around a big city, okay, and you get to a dark alley, okay, what happens? What happens to you? If you know that you have to walk through that dark alley, well, for most of us, there's kind of a fear reaction. We start thinking about dark alley, could mean danger, crime, million and one other things, right? And if we have to walk to that dark alley because we don't have a choice, we're going to be very alert, and each little noise is going to make us react because we're expecting the worst to happen. Children that have experienced trauma tend to live that way 24 hours a day, 7 days a week. We had a child once in one of the foster care programs that I used to work with where she's in a stable home, had been in the home for 2 years, kid was 13, she was a little girl, little for 13. One day, she is driving in the passenger seat with the foster mother, and the foster mother saw a baby deer at the side of the road and did this. Oh, look! You know what the kid did? Bit her arm. That was her reaction. Her instinctual reaction was, you raise your hand and put it close to my face, I think you're going to hit me. And to defend myself, I'm going to bite you. Didn't mean to do it, but that was her instinctual reaction. Just because by the foster mother doing this, foster mother thought she was pointing at the deer, the child thought she's going to hit me. Children with, that have experienced trauma are going to be hypervigilant. A lot of behaviors, a lot of words that we could interpret as being just normal, regular, everyday things that we say to other people or we do with other people, to them, it could have a completely different meaning. And a lot of their reaction is going to be based on that.
I just have one question going back to the other one, the difficulties with learning and short-term memory. Is there a possibility that a child, let's say, who's on the autism spectrum, not severely autistic, but mildly autistic, could that cause problems with short-term memory?
Oh yeah. One of the things, let me just tell you this story. One of the things I love about my son is he will tell you exactly what he thinks at any given time. Takes things very literal. So if you ask him a question, he's going to answer that question. Okay? So one day we were walking, just to make you laugh, one day we're walking into Walmart. He was 11 years old and he's scratching himself. And I'm thinking, I have to make him stop doing that because he's walking in front of me. And I said, Sam, what are you doing? You know what he said? Scratching my ass. I asked him the question. Now, one day, I can't even remember what we were talking about. But I'm trying to get him to understand something. And it was one of those days that if I would have been a different parent, this would have been the day that I would have abused him. Because I was frustrated with him. And I'm telling him, Sam, you gotta understand. At some point, just hit me. I said, okay, I want you to tell me what exactly did you hear? You know what Sam said? Blah, 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 blah. That's what he heard. So I'm explaining these things to him, and for him, I'm not making any sense whatsoever. I'm using language that I could understand. I'm using language that his brother could probably understand. And he understands the words, The message that I was trying to get to him at that time wasn't coming across. And that's part of his disability. Part of, he doesn't like hearing me, but that's part of his disability. So yeah, those things, and we'll talk a little bit in a little while about then what do we do about that? How do we communicate in a way that the child could understand? Okay? Now, if we look at the resilience literature, and the resilience literature is the literature that tells us what is it about kids that make them survive. Like, we all see the kids in the foster care system that have gone through like really difficult situations and then do really well. Why? Why do some do well and why don't? There's a whole bunch of literature that have tried to study this, like the resilience literature. The resilience literature tells us that children that tend to do well after facing trauma have this particular characteristics. Good intellectual functioning, appealing, sociable, and easygoing, and have an easygoing disposition. Okay? Self-efficacy, self-confidence, high self-esteem, and talent. Now, think about a child with developmental disabilities and tell me how many of those most of the kids with developmental disabilities have. Because they have developmental disabilities, usually their intellectual levels are in the borderline, if not lower. Right? So they may have an IQ of 75, 70, 65, depending on when you test it. Okay? Some children with developmental disability may be very likable. My son is, everybody loves him. But he's definitely not easygoing, and he doesn't have an easygoing disposition. On the contrary, most of the time, you kill him. You see what I'm saying? So the characteristics that make children successful after experiencing trauma are exactly the same characteristics that tend to be absent in children with developmental disabilities. Okay? In a little while, we're going to talk about how do we create this in children that have a little bit more difficult. Okay? Okay. There's a couple of things that, as we talk about treatment, there's a couple of things that I want you to that I want to discuss with you, I guess. One is the idea of cure. Okay? So, if you experience trauma, what does cure look like? How do you get cured from a traumatic experience? Any ideas? Most of the treatment, it's not designed to cure. It's designed to make better, to increase the level of functioning. The majority of kids, the majority of adults that have experienced trauma, the research tells us that even when they are functioning well, they will still experience emotional turmoil, anxiety, depression, hypervigilance. Not all the time, but, and we also know that adjustment, positive adjustment, it's not a universal term. Positive adjustment is subject to situation, subject to developmental task, and subject to time. So a child doing well now, and let's say they're 14, doesn't mean that they're going to do well when they're 15 and maybe start dating or go into high school or change homes or move back with their natural parents. So usually when we think about treatment, we think about what are the goals of treatment. Okay? And the goal of treatment is for competent functioning, or at least functioning at the expected level for the particular child. Right? We want to reduce behavioral difficulties. We want to increase the successful navigation of developmental milestones. And we want to increase the ability to regulate emotions. So for most of our kids, we're not talking about curing them. Treatment models. Have you ever heard of any of these?
Like,
Yeah. So we're going to talk just for a little while about some of those. But before we do that, you know, my grandmother used to say this, and she used to say it in Spanish, so I translated it, and I'm sure it's a saying in English, but not everything that shines, not everything that glitters is gold. You know what that means? Not every treatment is effective. There are some people out there doing the greatest things in the world. Not every treatment is effective. We had an issue in Pennsylvania, and our managed care company got to the point that kind of told me, don't ask the question again. Managed care company in the county that I worked with in Pennsylvania had a category of services called specialized services. And a therapist would bill specialized services, and they would pay specialized services at a higher rate. The challenge was this: what we classify as specialized services was the need of the child, not the specialty of the therapist. So, if a child needed services because they had experienced abuse, that was specialized. If the therapist had no experience in treating a child with, that had experienced abuse, that didn't matter. Because it was based on the need of the child, not the specialty of the therapist. And my argument to them was, how can you call it specialized services if there's no specialized therapist? The therapist has no clue what they're doing because they're not specialized in this. Right? So it's not a specialized service, it's a specialized need, but it's not a specialized service. So like I said, we got to the point that I would walk into a meeting and the lead psychologist would look at me and say, don't ask. Not discussing that again. Now, treatment that are considered evidence-based. For treatment to be considered evidence-based, for treatment to be considered to have evidence that it works for that particular difficulty, it must show evidence of positive outcome based on peer-reviewed, randomized, controlled trials. Scientific test that it actually works. The therapist telling you that it works, or one of the main measures of treatment success that's commonly used is client satisfaction. Client satisfaction is a measure of how much the client liked the therapist, not how successful the treatment was. Promising practices. Promising practices are precisely that. Are practices that appear based on what they look like to make sense and work, and may have some evidence to them, but not at the level of being kind of scientific evidence. Right? Now, another term that you would hear a lot is trauma-informed and trauma-informed care. Right? Trauma-informed care is basically treatment that is grounded on the understanding of the responsiveness to the impact of trauma. Trauma impacts people in many different ways. Treatment that is trauma-informed is treatment that takes those ways into account. When I was starting my career, a long time ago, I was assigned this child, 7-year-old girl. Was doing an intake, walk her into my office, close the door, and this kid froze. Like, the change in her when I closed that door was such that I did this. Closed the door, looked at her, opened the door, left the room, and got a female therapist. Because I thought there's no way on earth this kid is going to talk to me behind a closed door. Why? Because she had been abused by a stranger that broke into her house. And being with me in a locked room, what are some things for her? So if we have a good trauma-informed care system, we would recognize that and address it immediately. If you have a therapist that's in a situation like that and says, well, this client is resistant because they don't want to talk to me, that's not a trauma-informed care system. Right? Okay, keep going. We'll talk about this once in a little while, though. And I'm going to leave Michelle with you to talk about one of the interventions. We'll talk about behavioral analysis. Okay?
Can everyone hear me okay? Yes. Does anybody know what ABA is, or Applied Behavior Analysis? Have you worked with a behavior analyst before? Good experience?
Don't answer that question.
Don't answer that question. The reason we talk about this is today we're going to tell you what you should get from a behavior analyst if they go into your home when you ask for a referral from a behavior analyst. Because just like any profession out there, there are good and bad and all. What is applied behavior analysis? I use this quote in almost every presentation I use. Research has shown that most effective way to reduce problem behavior in children is to strengthen the desired behavior through positive reinforcement rather than weaken through punishment. Basically, that's what it says. Instead of negative consequences, that doesn't change behavior. That doesn't give a tool to a child on how to get what they want in an appropriate manner. All it does is it punishes or stops the behavior. And why we say we all are experts at blocking behavior, but we're not so great sometimes at shaping or changing behavior. And that's really what this means. Everyone has behavioral issues, all of us. I have them, Dr. Posey has them, everyone in the audience has them, so identifying them is really important. Many people learn new and appropriate skills as they get older. We grow out of them. As you were speaking of your 4-year-old granddaughter, she's going to grow out of some of that because you're going to strengthen.
Hopefully a lot of that.
Hopefully a lot of it. You're going to strengthen it through reinforcement and attention and those things, and not necessarily through punishment. For people who don't grow out of it, they require formal treatment. That's where ABA comes in. What is the question? How do we change behavior? In order to change the behavior of an individual, we must first change the behavior of the people around you. So, go
Right,
ahead.
interrupt you for 1 minute.
Absolutely.
Let me ask, why do we want to change behavior? So if we're looking at trauma, we're looking at children with disability, we're saying children with disability that have experienced trauma will probably experience or exhibit behavioral difficulties. Why do we want to change that? Any ideas? I told you before, you gotta speak one at a time. Begin. What tends to happen if a child is in a foster care program, they're in a foster home, and their behavior deteriorates significantly?
They could lose their place.
They're to lose their placement. That's one of the basic consequences. What else?
It's a safety issue sometimes.
It becomes a safety issue, and as we know, when it becomes a safety issue for the child, then we start thinking about more restrictive placement, Baker acting, physical restraints, all those things that could have the side effect of re-traumatizing this child. Right? That's part of the reason why it's extremely important to be able to manage those behaviors so that the child doesn't end up being re-traumatized as a result of the behavior that they're exhibiting because of their trauma.
You mentioned it earlier when you talked about trauma-informed care. All these interventions go hand in hand and they do overlap. So if you know that being in a locked room is going to trigger behavior or re-traumatize or whatever lingo we use, we want to change our behavior. We want to change. That may be your practice when you provide treatment. But maybe with this individual, that's not what I'm going to do. So it's much easier for us to change what we do, how we approach, how we talk, where we stand, not point and put your hand in front of someone if you know that. That may be fine for 9 out of the 10 kids you see, but you need to be aware. That's where the individualization will come in. Why is the person acting that way? I tell everyone this, and it's not just about individuals with developmental disabilities, but everybody does things for 4 reasons. We call it function. It's the why. It's the why of behavior. Here they are. We either do it to escape, we either do something to avoid, we do it for attention or for access, and then we have automatic. We do it for 4 reasons. So if you could go about your daily business and say, why am I doing that? You're either trying to access something, you're trying to escape something or avoid, and the attention is really the access, or you're doing something that's automatic. It's just intrinsically rewarding to you. And all our kids, whether they've gone through trauma or not, they're doing it for the same reason, whether it is to avoid being re-traumatized. So we have to look at that. How do we determine why people do what we do? How do we do that? As we talk about treatment and we talk about what you get from a behavior analyst, you're going to get 2 things, hopefully, from a behavior analyst. The first part of it is the assessment part. So they're going to come in and they're going to actually do what we would call an FBA, which is a functional behavioral assessment. That is not the treatment part or the intervention part. That is just the observation part of the assessment. They're going to come in and observe, hopefully talk to the parent, observe the child, talk to caregivers, talk to the school if that's what's needed, and they're going to come to a conclusion on the why. Why are kids doing something? And hopefully make recommendations on what they feel will be the most appropriate next step. When they do that, they're going to keep in mind, of course, the medication, the illness, sleep, all those things, any other factors that may be contributing to any type of trauma, as Dr. Posey said earlier. During their observations and their interviews, they're going to talk about with the parent or with the child, if the child is verbal, and they're going to do observations. They're going to look for things that trigger behavior. Anything that may be changing in the environment, whether it be somebody that enters the room, leaves the room, is it weather, is it medication, are there loud noises, is it dark, am I in a room by myself, anything that may trigger behavior. We get a lot of individuals that we ask to take this type of data, and they'll say, it happened out of the blue. Nothing happens out of the blue. What happens is that you just have not identified what it is. It could be very, very minor. Something sometimes known as triggers can be situations, events, or an area.
You talked about triggers, particularly with traumatized kids. We realized that one of the strongest senses in our body is smell. So there are smells that could trigger ideas of trauma for children.
A lot of the kids we work with currently, textural or touch, tactile is a big issue, and we have a young lady who doesn't like to keep her clothes on, which, as you can see, not that big of a deal, not a safety issue while she's in the comfort of her own treatment facility or home. However, a significant issue when she's out in the community. You can't have a young lady running around with no clothes on. So through assessment, we figured out she hates the feel of almost every single type of material. She had a medical illness, which was a rash, and that just precipitated the whole agitation. So now we're trying to figure out how do we get her to keep clothes on. Because if we get her to keep clothes on, she wants to bite us, she wants to hit people. So it's really, you have to look at all the different things. Yes?
How do you address some of the acting out behaviors that come up because of things that are happening in therapy or behavioral?
Can you give me an example?
We have a young girl who was not very communicative and was taken months to really, in her wraparound services and therapy, to even get her to start disclosing some of the things that happened to her. And now her behavior is deteriorating rapidly in school and in the foster home, and to the point where the foster mother is disrupting her placement. And so the behavior she has wraparound services, and while these things are being disclosed, she's now exhibiting more behaviors. I'm wondering how you...
That's really difficult because you're talking about something that she's reliving something that was probably pretty traumatic. And she's acting out, and it goes back to one of the first slides about how she's communicating and how she's expressing. So the behavior analyst or the therapist, the RAP services probably really need to look at different avenues for her to communicate outside of the acting out. That may not be to verbally communicate, but just physically communicate something that she is going to cope with those feelings, those internal feelings that she's having. And it really is a trial and error because every individual is going to respond. Some people like to journal, some people like to exercise, some people like to throw a ball, punch a punching bag, something. So in the behavioral world, we call it shaping. We're going to shape that physical aggression or self-harm, whatever she's doing, into something that's more appropriate.
She's targeting kids that have done nothing to her, saying that she knows they don't like her. So she's
And what happened? I would say, what happens after she targets them? What happens with her?
I assume because it's in the school environment, after school environment, that she sits. And she's getting referrals, she's getting written up, she's getting the...
She probably escapes some of the things that she gets away from the kids. The easiest way, I always say it's 100%, it's foolproof. If I punch a peer, what happens with me? I get removed from that environment. That is foolproof. Am I allowed to leave that environment if I ask? Probably not.
Right.
But if I punch, then that's a guarantee. It's like that insurance. And it's sometimes really difficult to manage your school environments that you have to really sell that. I was saying, it's like selling a used car. You have to get them to buy into. If she asks to leave, we let her leave. And if you gave her that green light, would she actually get up and leave if we allowed her? No, but she punches because she can leave.
Why, question that something you said, why get her to talk about what happened to her? What was the purpose of that?
Well, from a legal perspective, because I'm a lawyer, there's
Okay.
concurrent criminal cases and termination of human rights cases going on. And she both experienced trauma and observed her sibling experiencing trauma. And we need, from an evidentiary purpose, we need to get at that so that we can do the right thing for her. So,
And the reason why I ask that is because it's not uncommon for many therapists to kind of believe that tends to be kind of the crucial part of treatment. And it is part of treatment, but if a child is functioning relatively well, they've created a situation for themselves where they could protect themselves from that trauma. Whatever it is that they're doing to do that. Many times, when we get the child to talk about it, what we're doing in a way is removing that protection. When you think about if you had a broken arm, and one day the doctor says, I'm going to take the cast off and you're going to have to walk around with your arm dangling. It's going to hurt. And that's what, in many ways, that's what we're doing. We have to do that for legal reasons, unfortunately. Preparing the child for that as much as possible becomes very important. And that we do depending on the child, depending on the experience, depending on how verbal the child is. But preparing the child for that experience becomes very, very important. And for this kid, maybe part of the therapeutic task is how do you recreate for her, how do you help her recreate whatever was there that was protecting her from that pain. It's just a difficult situation for a child. It's a difficult situation because it happened to them. It's a difficult situation when the parents are the ones and she has to tell you this and know that whatever she tells you is going to go against her parents because whatever happens, those are still her parents. And it puts kids in a really difficult, and again, for legal reasons, we have to do it. Figuring out ways of how to help the child continue to protect themselves from that pain becomes very, very important. In that case, though, let me just tell you, in that case, one of the most important things that you probably do for this child is write out the behavior with her. Whatever the intervention is, whatever you do, she needs to know that she's not going to be rejected, that she's not going to be re-abused, that you're going to work with her, provide whatever interventions, but that she's still going to be safe.
It's problematic, and this is not the only case I have like this, because I can't promise you that, none of us can, because it is disrupting the
And that's the biggest challenge. Because then, again, then it almost becomes a kind of a self-fulfilling prophecy. It also becomes reinforcing for the child in a way. Because then they know that one of the ways of disrupting their placement is by misbehaving. Because the misbehavior, so if they're in a foster home that they don't like, they could do that. But also if they're in a foster home that they begin to get scared because they begin to connect.
And they do that too.
They could do that too.
Sabotage, yes.
Yeah.
And that's where it becomes very difficult, and I'm using very layman terms about figuring out other ways for her to express that. And I know it's a lot easier said than done, but that really is not giving up. And yes, it's disrupting the classroom, and it may disrupt the foster home, but really starting right at the beginning and getting that plan with her of what we're going to do instead of these things. Because the one thing we do know is that she knows exactly how to go from one place to the next, and the only guarantee is when I act out, get law enforcement involved, court systems involved. And then we talk about the consequence, and I think we kind of went right into that, where it's not about the behavior, it's really what happens after the behavior that's going to solidify what's going to happen in the future. I have this saying is the best predictor of the future is the past. So whatever you were doing in the past to access something is exactly how you're going to do it in the future. We do it every day, how we drive to work, the way we eat, the way we get dressed, make our bed. We're very repetitive people, and we get natural reinforcement from how we do things. Same thing with the case that was just brought up. That's all she knows, because we're not teaching her, or we don't realize we weren't teaching her other ways, and she hasn't been using those historically, so she's not confident that in the future those things are going to work. We have to be there to guide her along and give her those options. And that's what the consequence part is. It's not a consequence of punishment, it's just literally what happens right after the behavior. And I'm going to skip the excuse me. This is just something a Will Press lever for food. If everybody that was cute. Everything's teachable. So, talking about skills building and reinforcement, everything is teachable. Functional skills that will help someone be more independent. Just a few examples are communicating, not just verbally, cooking, cleaning, any type of life skills, guidelines about functional skills, accessing your needs and wants. Even if your need and want is to get out or escape, that's still a need and a want. We need to figure out how that's done appropriately. And then we work on how the tolerance part of it, because I realize you can't allow individuals to constantly escape and never access school and never do those things, but you have to build that trust with them first. Should be age appropriate, environment appropriate, and the more the skill is needed, the more functional it becomes. So skills for me versus Dr. Posey may be a little different because of how much it's needed. Why do we teach it? Why do we teach functional skills? Or in the behavioral world you may hear acquisition or replacement. They promote self-awareness, independence, helps individuals learn skills quickly, and prevents behavior problems. If you know what to do instead of a behavior problem, we go back to everybody knows how to get arrested in here, right? Exactly. That's a full proof. Everybody knows if I beat somebody up or hurt myself, I can get bank corrected, I can go to juvenile detention, it's a foolproof plan, I can get out of this building right now if I wanted to. They don't know how to do that sometimes functionally, and that's where we come in. Making sure that is, I would go back to say, for every negative comment or negative intervention that you have to use, we should use a positive 4 times more. So it's not about how, even if someone acts out 10 times a day, that means 40 times a day we need to find something to tell them they're doing right and build that self-esteem, build that self-awareness, and build that skill. Yes?
Can I ask a question?
Sure.
What about the child who, as soon as you do all the reinforcing attaboys, child immediately then reverts to the negative behavior. What is that telling us?
Because that's their 100% foolproof, because they learned prior to you giving the reinforcement or that avoidance that day, or that week, or that month, is I know for sure this is the easiest way. Or we're wrong. We may be off. Maybe they're not doing it for attention. Maybe they're really getting something else from it. They're either escaping, or that's where the assessment comes in. And assessment isn't just at the beginning, it's ongoing. So that data that we ask people to take, because that's what will happen to behavioral analysts. The second part of treatment is you come in, and now that you have your functional assessment done, and you're here, you've given it to the parent or the school, you're going to ask them to take data. And a lot of people don't understand why we ask them to take all those hash marks, but we ask them because that's going to tell us if something's working. And if it's not working, it's okay that it's not working. We know we need to go back to the drawing board. Because the way it looks, like to the naked eye, sometimes isn't always what it is. So kids will actually run out of school, not because they want to escape math class, but because when they run out of school, they have someone following them and they get one-to-one attention. So maybe it's really the attention they want, not the escape from math class.
The idea is that we do something for something. And the challenge is, how do we discover what this kid is getting out of that? And how do we get them to get that same thing in a more adaptive way? What they get out of it? It's not easy. I mean, if it was physical, if it was clear, it would be really easy. But sometimes it isn't. Let me give you an example that always made me laugh. I used to do consultation work with preschool kids, and we had a teacher. Her name was Gloria, and I used to call this the Gloria effect. And Gloria is a very good friend. One of the things Gloria would do with some of the kids is she would give them a hug. Hey, well, Gloria was very well endowed. And I used to joke with her, and I would say, okay, Gloria, what do I need to do so you give me that hug? To get her to understand that the child is misbehaving. He is getting that physical contact with her. And, you know, for him it wasn't, for the kids it wasn't sexual, right? But he's getting, and they wanted that, they liked that. But it was set up in such a way that the only way they would get that was when they would misbehave. And it's like, okay, how do we change that so that if they need that physical contact, they're getting it as a consequence to a positive behavior, not to a negative behavior. And this is really crucial because if you don't manage that behavior, almost everything else you could do in treatment could be lost. So you could have, this kid could be in therapy and they could be making wonderful progress, but that behavior could lead to a placement disruption, which would make things a lot worse for them. So managing that behavior, it's almost like a first aid triage thing that you have to stop the bleeding so that you really know what's going on. Does that make sense? So part of the trick is figuring out what is he getting out of that behavior. And it may not be something concrete. As adults, we have a lot of internal, intrinsic motivation. And a lot of us do many of the things that we do, and we say, well, we don't get anything out of it. Yeah, we do. We get satisfaction, we get some recognition, we get something that makes us feel good because we do that. With kids, it's figuring out what is it that they're getting out of that behavior.
And it's very difficult, and if you have any behavioral services that you're working with, it doesn't stop, it has to be ongoing. If I can give you any recommendation, because as kids acquire skills, sometimes function can change. Because now they're confident, and then things have, so it's not a one-stop shop, here you go, I'm done, he does it for this, and you move on. That's not going to be effective. It may help for a short period of time, but it's not going to help for a long period of time. And this is just, you can teach anybody something, a fish jumping out of a bowl, and that's it.
talk about a couple of other things. I'm going to talk really fast just because I know that time is, okay? TFCBT. Somebody at some point asked about ways of treatment. Okay. Trauma-based cognitive behavioral therapy is a somewhat manualized treatment to deal with issues of trauma. And one of the things that many therapists have done and have been researched, not very well yet, but it's in the process, is how do you modify the curriculum for trauma-based CBT to apply it to children with disabilities. A couple of the things that you do is, again, with children with disabilities, you're looking to breaking down lessons into smaller parts. Okay? Trauma-based CBT has a number of sessions and tasks that you have to do in each one of the sessions. So increasing the number of sessions, breaking those down and allowing children a greater amount of time to complete those particular tasks becomes using experiential opportunities to complete some of the tasks. Again, with many children with developmental disabilities where communication is an issue, you need to understand that communication is kind of a two-way street. So you have to kind of assess, is it a child communication issue or is it a therapist listening issue? Hmm? So the therapists need to be able to kind of figure out what language does this kid speak and try to understand what that language is. One of the really probably wrong examples, very inappropriate examples I give people sometimes is that of my dog. I have this wonderful dog that I adopted from a service dog program. The service dog director always hated when I said this, but he was a reject. Because he went through training and he decided right before he was placed that he liked to chase squirrels. And so he has all this training. Probably I look at him all the time and say, you are the best trained dog I could ever imagine. Okay? Amazing little dog, very intelligent, and he communicates. He'll tell you when he's hungry. He tells you when he wants to go outside. Now he doesn't use words. Right? If I were waiting for him to tell me, you really got to go, you got to walk me now, I would have a heck of a mess in my house. Right? I need to understand the language that he uses. I know that's a really inappropriate example, but with children, we have to understand the language that they're speaking. And many times, they're not going to use words to tell you the things that they have to tell you. You need to kind of have an open mind to try to understand what that language is. And many times using experiential opportunities and kind of changing the language and the delivery method. So what that means is that you have a lesson to teach. Use something that the kid would appreciate. Use a song, use a TV show, use a video game. They know that those kinds of things. We do know that many children with language delays love music and learn the songs. My son learned, and I hate this, but he learned the words to the song from the Backstreet Boys before he learned how to talk. And he could sing the song because my daughter was around that age and she was listening to the Backstreet Boys, and he would sit in the car and sing the Backstreet Boys songs. Couldn't tell you anything, but he could sing the Backstreet Boys song. Finding different ways of communicating the lesson and listening to what the children are trying to tell us. No. You all right? You go back. Back. All the way back. Because there's one side, I didn't put it.
Am I going to be
Yep, keep going. Yep. Going.
Oh, okay.
Power I have here, look at that. Make this change.
There you go. Here.
One more? More? Yeah, more? Hey, you go. I do this with my kids sometimes. Just tell him, you want to see how much that changed. And they go, he looks at me, he used to be evil when he was little, now he just looks at me like that, please. Play therapy. Now, what is play therapy? Many people think play therapy is the kid goes into the session and starts playing, right? That's not play therapy, that's a break for the therapist. Play therapy is really kind of the use of activities that the child enjoys and it's involved with if you wasn't doing a task, to teach, to redirect, to address different issues. She tell people the best way is when you're doing therapy and the kid doesn't know that they're in therapy, because they're using what is natural to them. Expressive therapies, art therapy, painting, drawing, building things, singing, some kids rapping, dancing. Animal-assisted therapy. Have you ever heard of animal-assisted therapy? My oldest son, about 4 or 5 years ago, got involved in a horse therapy program because his brother was going to that, and I couldn't go with him, so my son started going, and then he got into this, and now he's really into this, and it's really amazing what people do with animals. Now, this is the amazing thing about it. When you look back at the research, the resilience research that we talked about before, there's a number of studies that are qualitative studies that have been done on resilience with adults that have experienced trauma. And what the researchers have done basically is they've gone and talked to these folks about what is it about their process that helped them get better, that helped them overcome their trauma. Almost 100% of individuals in those studies have said that before they could rebuild relationships with people, they built relationships with animals. Dogs, horses, cats, adopting a dog, adopting. So you hear stories after stories of people saying, what helped me relate to my girlfriend now is that I, 4 years ago, went and adopted this dog and realized that I connected with them, and I could connect with them because they were safe. And that helped me connect with people. So there's a big impact in that. Giving back. In those same set of studies that I just mentioned, another one of the themes that continues to come back for folks is the opportunity to give back, to do something for somebody else. So providing opportunities for our kids, and it's something we don't think about a lot because we tend to think about our kids more as service consumers, but volunteer opportunities to do something that gives them the opportunity to feel like they're doing something for somebody else. It's a very big issue. Normalizing activities. What are normalizing activities? Activities that they will do because they are kids. Two things that you need to think about in terms of normalizing activities. Children at a certain age in our country are used to doing certain things. It makes sense to try to help our kids be involved in those same activities in the way anybody else that wouldn't be in the foster care system, or that wouldn't have a disability, or that wouldn't need treatment is doing. So playing baseball, playing basketball, joining Boy Scouts, Girl Scouts, all those activities that other kids their age are doing are kind of just normalizing activities. The other thing that we need to keep in mind is not every behavior, and not every inappropriate behavior that a child has is a result of the trauma. Okay? Kids are a pain in the behind sometimes. And that's part of being a kid. Okay? And sometimes they're not behaving because they're in the foster care system, or because they have a disability, or because they experienced trauma, but just because they're a kid. Right? Like I said before, my 4-year-old granddaughter, she could write a book on temper tantrums. Right? And it's not because there's anything wrong with her, it's because she's 4. And 4-year-olds throw temper tantrums. Okay? Skill building and practicing competence. Okay? We're going to go back to that set of studies that we talked about. Another one of the themes that comes up in that set of studies for folks, part of the, I call it the curative process for them, what helped them get over the trauma was having the experience of being competent in something, having something that they were good at, that they could do. Again, that creates the sense that excuse my language, I'm not a piece of crap. There's something good about me. There's something valuable that I have to offer. So creating for children the opportunity to do what they are good at. Now, this is difficult for kids, right? Because sometimes with some kids, it is really hard to find things that they are really good at. And let me tell you 3 things that you could think about. Okay? Find things that they just do now that they're good at and reinforce that. Okay? We were talking about this before. Kids do not behave inappropriately 24 hours a day, 7 days a week. Okay? We focus on the behavior that is negative, but if we actually were to calculate it, the behavior that is negative will probably be a much smaller portion of their behavior. So look at those things that are positive and try to increase that. If you increase the positive behavior, you will reduce the negative behavior. Okay? So figure out ways of reinforcing the positive behavior. Second thing is create the opportunities for those positive behaviors. Okay? So if you tell a child, the foster parent tells a child, go get me a fork, and the child goes and gets a fork, it's a positive behavior. They got you a fork. Okay? Create that opportunity. Okay? The third thing to keep in mind is think small. Okay? Many parents and many foster parents do this. They're like, oh man, they took a shower today without you telling them. And the response is, well, they should do that every night. They took a shower today. Think that small thing, it's a big step for them. Okay? Don't just think of, I'll reward them when they take a shower every night for 2 weeks without me telling them. Think about those small steps. Think small. There's some small things our kids do that is positive. And when we could incorporate all that, and again, the trick is figure out how to manage the behavior so that the child is not in a situation where they're being re-traumatized. They don't lose their placement. They don't get in trouble. Okay? Stop the bleeding, and then provide them with all these different opportunities so that they could increase their level of adjustment. Never going to get cured. I'll end with this story. And I know I say a lot of stories. When I was little, I used to live with, part of the time with my grandmother. My grandmother lived in the middle of a sugarcane field. It was amazing because I love sugarcane. Problem is that when they're about to cut the sugarcane, they burn it. Now, my grandmother didn't want us in the sugarcane field. But when they burned the sugarcane field, there were ashes all over the place. So we would get into the sugarcane field, we would walk out of the sugarcane field and try to remove all the ashes that were in our clothing so that my grandmother didn't know that we were in the sugarcane field. We couldn't remove the ashes. We could clean ourselves up. But when we got to the house, my grandmother would say, you were in the sugarcane field because you still have ashes. All right? Children with trauma is very similar. We're cleaning them up. We're trying to make things better for them. They'll never forget that trauma. That's always going to be with them. That's always going to impact them. And there's always the chance that issues related to that trauma will come up at different times of their lives. So part of our goal with treatment is really to create a situation that when those issues come up again, they're in a better position to deal with them so that they don't cause them as much difficulty as they did at the beginning. Okay? Thank you, and we are running out of here. Any questions about it?